So we have a cost imperative and we have a quality imperative to fix this issue. So let's turn to that. There has to be a better way. Now, Tom, you've been describing some new models. What is that better way?
There are people who are beginning to develop what I would call the primary care practice of the future. And it's very different than the primary care practice of the past. So number one, when a primary care physician walks into the office, it's not saying, okay, I have 30 15-minute visits that I have to accomplish before I can go home tonight. The primary care physician will walk into the office and say, with my team, I am going to spend my day trying to make my panel of patients as healthy as possible. That might be a visit, a traditional visit. It might be working with people on email, on phone, on group visits. It might be having a panel manager who says, this is the panel of patients. These are the people who are overdue for mammograms, for pap smears, for immunizations. These are the people in my panel with diabetes, whose hemoglobin A1Cs are too high, who haven't had a hemoglobin A1C in the past year. We're going to contact these people. We're going to bring them in for the lab tests they need. And if they're out of control with regard to their chronic disease, they're going to meet with a nurse who has a physician-written protocol as to how to increase their medications to get their sugars back under control. So we're going to look at the whole panel of patients and try to make that panel healthy, not just concentrate on the 15-minute visit. I think that the primary care physician of the future should probably see about 10 patients a day, should spend real time with those patients. Those should be patients that are complicated, that really need a physician to take care of them.
Well, I listen to you and I think, and what a wonderful world it would be. I mean, is this an abstraction? Is this a pipe dream? Is it happening? Is anyone doing this and doing it successfully?
Some of the large integrated systems are beginning to do this. So take Health Partners in Minneapolis. They have a whole system which they call the pre-visit, the visit, the post-visit, and the between-visit care. In the pre-visit, a medical assistant makes sure that everyone's chronic and preventive care tasks are taken care of and does medication reconciliation to make sure that the patient's medications are being taken as the physician or the nurse practitioner has ordered. In the visit, it's a traditional physician visit. But then the post-visit would be making sure the patient understood what happened in the visit. We know that 50% of patients leave an office visit without knowing what happened in the visit. So having a medical assistant, or in our case, a health coach, making sure the patient understood what happened in the visit, working with them on behavior change, and then phone calls between the visits to make sure, were you able to get the medications that you were prescribed? Did you have any problem with the copays? Did you have any problem with the formularies? Do you still remember how to take the medications? Are you taking the medications? If not, why not? And what can we do to try to take care of that problem?
What will it take in terms of the payment structure and the organization of medicine for these models to reach their potential?
Well, some of the systems that do the kinds of things that Tom is talking about actually redeploy their resources. They have an internal rule for what gets paid for and how it gets paid for and who gets what. So what they're doing is they're working within right now a distorted payment system, but they take those dollars and then they reallocate them in an intelligent, non-distorting way.
In the last 25 years, we have learned so much about what primary care is that it's almost a crime not to put it to good use. We know what the principles of primary care are, and it is almost certainly the case that there are many ways, or at least several ways, that you can accomplish these principles. Now, there are basically 4 organizational principles. One is you have to define your population. You have to know who you're responsible for, and the people have to know that they have a place to go. That's the defined population. That's one organizational feature. The second one is that that place has to be comprehensive. It has to provide a broad range of services. Okay? You can't be sending patients to this doctor, this doctor, this doctor. And it's probably why family physicians, on the whole, looking at it from a population person point of view, do better than any other kind of primary care physicians, because they're more comprehensive. They do a broader range of services. Okay, the third thing is some mechanism of continuity. You have to have some way to transfer information. You know, there are lots of ways you could do that. Electronic medical records is probably a very good one, but it's not the only way. And the fourth thing is accessible. Okay, 4 organizational features that you have to have in order to have good primary care. And the team may help doing one or more of those, but it's not that you have a team. It's that you're trying to accomplish a certain function, and sometimes a team helps a lot. And these principles of organization then translate into 2 essential features, which we basically in our quality systems don't focus on at all. What's the patient's problem, and has the problem improved?
We know the whole healthcare system has to change, and including the reimbursement structure, to get to some kind of relationship where we pursue these principles, but what do physicians have to do?
I think that what a medical team accomplishes is it offloads the things that are very important, the preventive screening, et cetera, but it then, by offloading that, allows you to once again focus on what is the patient's agenda. And I think, you know, obviously there are dangers to the idea of a medical team. I mean, if the doctor is actually never seeing anyone, but just sort of saying to the nurse practitioner, do this, or the medical assistant, do this, that's not going to be rewarding for anybody. But I think taking away from the physician those tasks which are easily accomplished, and which also, for most patients, don't have a huge emotional agenda going on with them, would allow us to have more time with our patients, to be aware of what they're worried about, and to do the things that I think most primary care doctors do, which is to show up at a patient's bed when they've had their mastectomy just to say hi. And that, or to call a patient, I know you just got your first dose of chemo, how did it go today?
Well, but I wonder if it's more than just offloading work. I wonder if there's something more to being a good team member. I think that a lot of our colleagues have difficulty working in teams, even if you surround them with teams. They have trouble delegating, even if you give them people to delegate to. Is this something, do you see this as a problem? And if it is a problem, what's the answer? Do we wait for the generation who feels that way to retire?
Well, you know, teams are difficult. If you look at the research on teams, there are a lot of dysfunctional teams around. And one thing is that if you have a team of 6 or 8 people, and they all sort of have to know what's happening, there's a huge amount of communication needed to make sure that everyone knows what's happening with a particular patient. That takes a lot of time, takes a lot of energy. Also, if you have a team of 6 or 8 people, probably one of the people is going to be difficult to deal with. But just statistically, it's more likely with a large team. We've been working with small teams, team of 2. We call it a teamlet. It's a small team, part of the bigger team. And it's really a throwback to the old days when you had like a solo doc, primary care doc, who was in an office with his nurse. It's always his, of course, nurse. It was always his back then. And they worked together like for 30 years. And the physician really knew what the nurse was good at. They worked together. There were only 2 people, so the communication was relatively easy. And the patients had trust in both of them. We're trying to reestablish that kind of teamlet idea because it makes much easier the team concept. Now, you may need to have a larger team around that little teamlet sort of focus, but teams, if we don't change the panel size, I think we need teams. And I don't think we can reduce the panel size if we have an increasing shortage of primary care physicians. The panel size is going to go up.